Hi everyone, this is Dr. Sneha Bhat, a reader in the Department of Periodontology in Yenepoya Dental College. Today my topic of discussion is a very simple yet a very valuable one, gingiva. This is what we see day in and day out, and every layman is also familiar with this part of our oral cavity, that is gingiva. But let us go in depth about what is it and what are the parts of gingiva and how it is important to us. So I'll be covering my topic under these contents: the introduction, the definition, the macroscopic and the microscopic features in brief. So coming to introduction, oral mucosa, as you all know, it consists of the masticatory mucosa. It includes the gingiva and the covering of the hard palate, the specialized mucosa that covers the dorsum of the tongue, and the lining mucosa that covers the remaining part of the oral cavity. The gingiva is that part of the masticatory mucosa that covers the alveolar process and protects the underlying tissues. So by definition, if we go, gingiva is that part of the oral mucosa that covers the alveolar processes of the jaws, and it surrounds the tooth or the neck of the tooth in a collar-like fashion. Coming to the macroscopic features, gingiva on the whole is divided into three parts: the marginal gingiva, the attached gingiva and the interdental gingiva. Let's get into the details of each of this in brief, and so that you all know what each part is and where is it located. Coming to the marginal gingiva, it's also called as the free gingiva or the unattached gingiva. Why so? Because it is that terminal edge of the gingiva that covers the tooth in a collar-like fashion around the cervical area. It is also called as free or the unattached gingiva, as I said, because it is not fixed to the periosteum of any alveolar bone. Usually it is around 1 millimeter wide, and it forms the soft tissue wall of the gingival sulcus that I will be talking about later. So this is in brief about marginal gingiva or the free gingiva. As you can see in the picture, it's the terminal edge of the gingiva that is present just below the cervical area of the tooth, around 1 millimeter wide. This is what I said, that is the gingival sulcus. As you can see in the picture, the marginal gingiva forms the soft tissue wall of the gingival sulcus. It's a V-shaped crevice that is present all around the tooth. So on one side it is surrounded by the tooth, and on the other side it is the free marginal gingiva. Ideally, the depth of the gingival sulcus should be 0 mm, but there is no mouth that is germ free. So for all practical purposes, the probing depth that we consider to be normal is 2 to 3 millimeters, beyond which the gingival sulcus is supposed to be known as a periodontal pocket. Okay? Until the clinical probing depth is below 3 millimeters, the gingival sulcus is of normal depth. Coming to the histologic features of gingival sulcus, it is lined by a thin, non-keratinized, stratified squamous epithelium, and as we all know, the non-keratinized epithelium does not have any retapegs. The function of this gingival sulcus is act as a semi-permeable membrane, and there is a fluid called the gingival crevicular fluid or the GCF that is present in the gingival sulcus that is very important. So what is GCF? It is either a transudate or an exudate depending upon the inflammatory content of the gingiva. In healthy sulcus, the GCF flow is bare minimum, whereas during inflammation it increases. It passes from the connective tissue to the epithelium and into the gingival sulcus. So what are the functions of GCF? 1. It cleanses the material from the sulcus. It contains plasma proteins for adhesion. It possesses antimicrobial properties and defense through antibody formation. GCF has now gained too much popularity in diagnosis of gingival diseases. Coming to the macroscopic, as I said, there is a marginal gingiva, there is an attached gingiva. Between the marginal gingiva and the attached gingiva, there is something called a free gingival groove. Okay, it is not present in all the oral cavities, but it around 30 to 40% of the adults have this free gingival groove that marks the demarcation between the free gingiva or the marginal gingiva and the attached gingiva. Next is your interdental gingiva. There are two types, one that is present between the anterior teeth and one that is present between the posterior teeth. The one that is present between the anterior teeth is also called as the interdental papilla. Okay? It's a tent shaped portion of gingiva. It is located between the space between adjacent tooth. The shape of this interdental gingiva again depends upon the position of the tooth, the shape of the tooth and the contact area. However, in cases of diastema where there is no interdental contact, the interdental gingiva is not seen, it is rounded. Coming to caul, so when you have a posterior tooth like a molar, we all know that the contact area is broad. So there is no way that the buccal and the palatal papilla can merge and become one as in your anterior teeth. So what happens? There is a depression or there is a space in between your buccal papilla and your palatal papilla, and there has to be something that connects this. That connection or the valley-like depression is called as the interdental caul. Why is it important? It is lined by non-keratinized epithelium, and hence it is anatomically predisposed for infection or growth of microorganisms and inflammation. So caul is very important because it connects the two papillae in the posterior teeth and it is non-keratinized. Coming to the mucogingival junction, you have the free gingiva, you have the attached gingiva, then what you have is the mucogingival junction. It is something that remains constant or same throughout life, alright. It is the junction between your attached gingiva and the oral mucosa. With age, there is an increase in the mucogingival junction in supraerupted tooth as well. Next is the most important part of the gingiva, that is your attached gingiva. It is that part of the gingiva that is tightly adhering to the underlying periosteum of the bone, hence called the attached gingiva, right? It is firm, it is resilient, and hence it is immovable portion of the gingiva. There are various methods by which we can measure the width of the attached gingiva. It is basically the distance between the mucogingival junction and the projection on the external surface of the bottom of the gingival sulcus. So basically you can just measure the distance from your mucogingival junction to the free marginal gingiva and then subtract the depth of the gingival sulcus. There you have the width of the attached gingiva. But why is the width of the attached gingiva so important? Because most amount of the keratinized tissue of the gingiva is your attached gingiva and it is fixed or connected to the underlying bone. Hence, it becomes a very solid support system for our gingiva. Coming to the dimensions, based on various studies, these are the basic ranges through which the attached gingiva can range. The maximum being in the maxillary incisor area, that is 3.5 to 4.5 millimeters. Mandibular incisors, it is around 3.3 to 3.9. Maxillary first premolar is around 1.9 millimeters and the mandibular first premolar is around 1.8 millimeters. So these are the basic dimensions which can change, but at least 1 mm of attached gingiva is now approved to be present. It is a mandatory. So why is it so important that we have to measure the width of the attached gingiva and make sure we have adequate width of attached gingiva? Because it supports the marginal gingiva, it provides an attachment or a solid base for the movable alveolar mucosa for the action of the lips, the cheeks and the tongue. It can withstand frictional and functional stresses of mastication and toothbrushing. It acts as a barrier for the passage of inflammation and it provides resistance to tensional stresses. So basically it acts as a buffer between the mobile free gingiva and the mobile alveolar mucosa. That is why attached gingiva is very significant when we come to the functions. So basic functions of the gingiva is to defend against the noxious external environmental influences that are present in the oral cavity. It also maintains the integrity of the body surface by separating the internal and the external environment. It attaches the tooth to their bony housing, resists and resolves the forces generated by mastication, and it also adjusts for structural changes that are associated with wear and tear by continuous remodeling and regeneration. Coming to the microscopic features, we have seen the macroscopic, now we see the microscopic. There are 3 kinds of gingival epithelium. The oral or the outer epithelium, okay, that is covering the outer surface of the gingiva. The sulcular epithelium that lines the sulcus, and there is something called the junctional epithelium which again is very important. It's a very small tissue, it's around 0.97 to 1.27 millimeters in length. This junctional epithelium starts when your sulcular epithelium ends, right? So there are 3 kinds of epithelium: oral or outer epithelium, sulcular epithelium and the junctional epithelium. Coming to the differences between all 3, Only the oral or the outer epithelium is keratinized. Sulcular and junctional is non-keratinized. The retipegs are present in the oral epithelium, whereas they are absent in the sulcular and junctional epithelium. Okay. Strata, granuloma and corneum is present in the oral, whereas it is absent in the sulcular and junctional epithelium. The defense cells are mainly present in the keratinized epithelium, like your Merkel cells and Langerhans cells, right? So this is how a keratinized epithelium looks histologically. You have the basal layer, you have the prickle cell layer, the granular layer and the corneum layer, alright. Whereas in the non-keratinized epithelium, you have the basal layer, the prickle cell layer, there is an intermediate layer and there is no layer called strata corneum because there is no keratinocyte present in the non-keratinized epithelium. After the epithelium, we have the connective tissue. The other name for gingival connective tissue is called as the lamina propria. There are two layers, one is the papillary layer and one is the reticular layer. It contains the main part of the gingival connective tissue is the gingival fibers. There are principal fibers and there are secondary fibers. We just need to know from where to where these fibers run and what are their functions, right? As you see in the picture, the tooth is all around surrounded by gingival fibers. As you go below towards the root surface, what fibers we see are the periodontal ligament fibers. But coming to the gingival fibers, we have the dentogingival, the alveologingival, dentoperiosteal, circular and transeptal. These are the principal fibers of gingiva. There are secondary fibers like periosteogingival, transgingival, interpapillary, intercircular, intergingival and semicircular fibers. Coming to the blood supply or the arterial supply, there are three main vessels through which the blood supply to gingiva occurs. One is the supraperiosteal vessels or the arterioles that come from the periosteum of the underlying bone. Vessels from the periodontal ligament, because one of the major functions of your PDL is to provide nutrition or blood supply to the overlying gingiva. Arterioles that emerge from the crest of the interdental septa. So these are the three main sources of blood supply to gingiva. So coming to summarize everything, the pH of the gingiva ranges from 6.5 to 8.5. The junctional epithelium and the gingival fibers together, they form a solid functional unit called the dentogingival unit. The junctional epithelium is important and it's a separate topic altogether. It's the only attachment between the soft tissue and the tooth and it is exposed to the external environment. Gingival fiber groups, they enable the gingiva to form a rigid cuff around the tooth, adding stability. Especially when a significant portion of PDL and alveolar support is lost, it is these fibers that hold on to the foundation. This explains that the increased mobility in periodontally involved teeth immediately after surgical procedures happen because these procedures disrupt or remove the gingival fiber groups transiently or temporarily. To conclude, I would like to say that the periodontium on the whole is an integral part of our oral cavity. In the periodontium, it is the gingiva that is very important for functional and aesthetic integrity, and the gingival health is the foremost purpose of oral hygiene measures, without which the entire foundation of our periodontium might crumble. So I would like to say pink health or gingival health is the way to general health. These are my references. Thank you.